Orthopedic surgical osseointegration. May I have the first speaker of this afternoon to the podium, please?
Jaha.
So, you're very, very welcome. And we now have presentations, which are four presentations from different parts of the world: Sweden, United States, and Canada. And I welcome the first speaker, Dr. Palmqvist from Gothenburg, who will talk about ultra-high resolution interface analysis of retrieved osseointegrated implants. Please.
Yeah. Thank you for the presentation, Professor Thompson. So I will, for you who were at the last session listening to Richard Bronemark and Peter Thompson, this will have a short recap for you who weren't here. So the osseointegration, discovered in the 1950s and defined as a direct contact between bone and implant material, and could be used as the bone-anchored amputation prosthesis, which I will concentrate the talk on, and I will mainly be on the method how to evaluate the bone implant contact. And as Peter Thompson described, there are many different animal experimental models. We want to look at the actual implant from patients, and it's very important to know how it looks from the patient to understand the experimental models. So it's an important process to retrieve, and there are many different reasons why you retrieve implants from patients. You can have adverse effects, lack of osseointegration, infection, osteomyelitis. You can have personal reasons, and fracture of the implant, for example. And you can also have more scientific reasons, post-mortem, retrieval, or if you have ethical approval, clinical function implants. And it's important, the steps how you retrieve the implants for the subsequent analysis. And if you have a lack of osseointegration, you can unscrew the implant, but then you don't have the bone tissue to evaluate afterwards. So the preferred way is to use a trephine burring, where you have a burr which you could use to get the implant and surrounding tissue out from the patient, and you will get a sausage like this. And so you have with the surrounding bone tissue, and you only take minimally amount of tissue around, so you could reuse the limb to put a new implant, for example. So as these are quite long, the implants, you can also have damage from the trephine boring. But usually you have very good tissue around. So when you have retrieved it, it's important to fixate the tissue, cross-linking the proteins by chemical means, usually formalin. It's a dehydration process where you take all the water out from the tissue. You resin infiltrate it and embed it so you have a workable block. And then you go down this line, you cut it in half, and you polish, and you can put it on a slide and sew out a thin section for light microscopic evaluation for histology and histomorphometry. And for those interested to see how these amputation prosthesis looks, it's a poster out 26318, where we have looked at 7 different implants retrieved from patients. I will not go into that now. That's hence the light microscopy. I want to expand how to look with electrons instead, to get a better resolution and many different possible analysis of the interface zone. So what happens when you use the electrons? They should be transmitted through the sample. There will be many different events occurring when the electrons penetrate and interact with the sample. So you will have scattering effects, which could produce different contrast phenomena in the analysis. And these are mainly elastically scattered. You can also have inelastically scattered. Hence, the electrons are losing energy while passing through, so you can sort electrons by its energy. And that energy loss is characteristic to what elements you have in the sample. And you also have X-rays coming out from these interactions. So there's a wide range of possibilities for different analysis to be done. So why aren't we doing it all the time? It's because it's very tedious to make the sample. It has to be less than 100 nanometers in thickness, which is very, very thin. And you want to have both implant and tissue in the section. And cutting tissue, which is relatively soft compared to a metal, they have widely different mechanical properties. So it's difficult to use the conventional methods in the material science or in the biological sciences. So we're using a microscope called focused ion beam microscopy, and we're actually continuing on the remaining block from the histological sectioning. So we put the block in the microscope, and on a micron site specificity, we can find an area of interest which we protect, cut out, and transfer to a TM grid, where we do a final thinning to obtain a 100 nanometer thick section. And I will go through one example of what we have looked at. The ulnar implant fractured after 11 years of use, was removed by trephine boring. Ground sections were prepared for histological section, for a histological evaluation, and it was quantified to be a large amount of bone tissue in direct contact on the light microscopic level. We made TM samples, and here we can see the titanium implant surface. Here we have the bone tissue with the characteristic collagen banding, and this zone here is a carbon-containing zone, which is most likely an artifact from the preparation containing the embedding resin. But looking closer in the zone of the interface, we see that we have bone tissue remnants, and then the polymer, and then comes the bone. So it's an indirect proof that it's an artifact origin from the processing, as we have the bone tissue. And we can filter the electrons by energy, seeing that we have calcium sitting directly on the titanium surface. And in high resolution, we can identify by measuring the lattice parameters to be hydroxyapatite and titanium. So we have the intact interface for the first time, as Professor Thompson mentioned. So the conclusions: we have developed a method allowing high-resolution analysis of the intact bone implant interface. It could be used for retrieved implants from human, and it could be combined with histological analysis, so we can get both the microscopic and nanoscopic evaluation of the implants. And we have also been able to show that you have a mineralized interface, which has been discussed in the 80s in the dental field, where they always found a proteoglycan layer at the interface, but with modern tools, you can see much more than the tools in the past. And I want to thank all people that are involved in the projects with the bone-anchored amputation prosthesis and the funding, regional fundings. And I will answer any questions you have. Thank you very much.
Thank you, Dr. Palmqvist. This paper is now open for discussion. Please use the microphones.
So, could there be a difference between dental and orthopedic implants when it comes to interface analysis? Will they differ? So, is this just technique dependent? You know, my comment to this, because I drilled out femoral implants as well as upper extremity implants, and much easier to drill out upper extremity implants because the bone density is much less. So could that change the interface characteristics, or could it be like time dependent? What is the reason? Is it technique, or is it actually a true difference between dental implants and orthopedics?
As a material scientist, I think it's quite difficult to answer the biological part, and I don't know if Professor Thompson has something to say about it, but there is a difference in load situation between the dental implants and orthopedic, and that will affect in one way. There is also a difference in bone type, trabecular bone, cortical bone, and what the cells are saying and doing close to the implant. So there might be a difference in the interface between different locations in the body, but it's also dependent on the techniques, how to analyze. So it's dual, I would say. And we need to look at more retrieved implants to find answers.
Thanks. We have time for a couple of more questions, please. Don't hesitate. Now you have the chance. Will you stay around here for further questions?
Yeah, I will stay the session out.